So thanks Raju, thanks Masterclass Series for inviting me, and I'm quite excited to show this case. So male 27 years, 2 months old, ACL tear, no concomitants, tense personality, always worried of unknown. And I'm always worried of such patients because they are always fearing of something unknown and something bad happens to them always, I don't know how. So it was a routine ACL reconstruction which we all do. It was nicely done, I was very much happy, and there was smooth post-operative period. So 1 month post-op, patient comes and no complaints, full range of movement, quadriceps is building up, and patient is happy, surgeon is happy. I'm going to show emotions here. If you can remove the timer from there, because those emotions will be hidden in this corner. Audiovisual guys, if you can remove the timer from that corner. So I'm showing emotions there because that is very important in a complicated case. What is happening to patient's mind and what is happening to surgeon. Thank you very much. Okay, so 5 weeks post-op, 7 a.m. in the morning, Monday morning, I received an emergency call. Patient says sudden swelling of operated knee. He was okay last night. He did some aggressive physiotherapy and suddenly swelling developed. I said, okay, come to clinic, I'll see. And patient was tense.
Yeah, timer ko opposite set kar do.
Patient was tense and surgeon was confused. What the hell can happen at 5 weeks? Anyway, let the patient come. And patient comes on examination. It is tense effusion, painful range of movement. It is warm on feel, no fever. I asked for CBC and CRP. They were normal. So I said, okay, something must have happened. I put him on NSAIDs, rest, ice, compression, and asked him to come after 2 days. Let's see what happens. Patient was still tense and surgeon was confused. You know, what could have gone wrong at 5 weeks? Let's see further. 2 days later, patient came back. Persistent but little tense effusion, painful range of movement. It's still warm on feel, no fever. So I said, okay, reluctantly, I need to tap the joint now. I need to see what is happening inside. It was largely a bloody tap. Hardly 0.5 cc of blood came out. I sent it for routine micro and culture sensitivity. Patient was tense, and as a surgeon, you know, whenever you are forced to tap a joint of your operated case, you are always worried. You know, you don't like to do that, and you're like, oh my God, you are always worried from inside. 6 weeks post-op, on examination, pain has reduced, swelling has reduced, culture report came, it was negative, routine micro was as per routine, repeat CBC is normal, CRP is 7, and patient is relaxed, surgeon slept well, okay. CRP was normal, and patient was relaxed, and I slept well, surgeon is me, so I slept well, that okay, something must have happened, and now everything is cool. 7 weeks post-op, again Monday morning, emergency call at 7 a.m., reappearance of swelling, pain increased, too much of stiffness. Patient said, I'm not able to move my knee joint. Again, no fever. I asked again patient to come to clinic, and patient was tense, and I canceled my gym visit. You know, surgeon gets mentally tense, you know what's happening, and then you don't enjoy your gym or your other physical activities. You're like, oh, forget about it. Let me see the patient. And patient came with self-MRI. Interestingly, patient is 200 kilometers away from my clinic. So he went to a local orthopedic surgeon and who said, hi, as Raju said, or Dr. Tandon said, MRI nahi karaya. So he got his MRI done. He started on IV antibiotics empirically, and patient came to me with this MRI. And when I saw this MRI, which probably I would not have asked or may have asked for, it was like very heartbreaking. Diffuse effusion all over the joint. Okay. So diffuse effusion all over the joint, throughout synovitis, extensive bone marrow edema in upper end TBR, lower end femur, mainly along the bony tunnels. The report was query inflammatory, query infective synovitis, and developing osteomyelitis. So my God. And patient was put on IV antibiotics by local orthopedic surgeon. Interestingly, total count was normal, but there was lymphocytosis. And I thought it was the time to involve ID specialist. And he said, okay, debride and remove the implants and graft and everything. It's an infected knee and you have to remove everything. So patient was tense, and as a surgeon I was scared because no surgeon would like to remove his ACL in 6 weeks or 7 weeks. And I was like, oh, what the hell? Okay. So some more pictures for the panel. Kanchanda, you must have seen some cases like this. Bloody environment, no fluid as such, and that explains why only 0.5 cc of blood came out on first tap, because there was no fluid inside, right? And I took tissue biopsy as somebody advised from here, and I said fluid for routine micro and culture sensitivity, and I thought that I should inform the ID specialist again, and he said, since you have taken fluid for culture and other things, now I'll start a broad spectrum, empirical injectable antibiotics and see what happens. So patient is in doubt. I was sort of relieved that it doesn't look like too infective to me, what was seen on MRI, and it must be something else which must be happening. So 8 weeks post-op, swelling reduced significantly, stiffness reduced, he started gaining the movement, biopsy was inconclusive, routine inflammatory changes, routine micro and culture was normal, and ID specialist say, okay, let's continue with the antibiotics and see what is happening. My antibiotics is playing a good role, that's what he said. Said, I put the good antibiotics. I said, okay. Patient is calm. As a surgeon, I also settled down that, okay, now it's a fight between the patient and the ID specialist, and they are managing the things. So I was like, okay, I'm good with that. 9 weeks post-op. Now this patient had a habit of calling every alternate day, Monday morning, 7 a.m. So it's, I don't know why. And now this time said that a bleb has developed on his knee, and the swelling has redeveloped on his knee, and the bleb was at 1 by 1 centimeter, if you can see on the top. Here, a large bleb around 1 to 2 centimeters square developed at the supralateral portal. That was where from where I did a re-arthroscopy while doing the lavage and everything. And this is a huge bleb which just popped out from there. And this is third time MRI which I did. So I reluctantly, I was not sure what I'm doing with, and I don't know whether I did right or wrong, but I decided to tap again, third time, in the hope that first 2 times there were no culture, so I might get something else. And I called microbiologist that, am I missing something? And he said, it can be fungal, it can be tuberculosis, it can be atypical bacteria. And he gave me the whole list of investigations, cultures, and frankly, I do not understand half of them, what they are meant for. But
may I ask what type of interference screw was used?
It is absorbable interference screw.
Biointerference.
Yeah.
Is it possible that it's some type of reactionary?
It could have been, but you know the similar swelling is in femur tunnel also. So I was not thinking on that term. Okay, anyway, I need to move forward because clock is gradually going back. And 11th week, I called ID specialist again, and he said, I will take the culture. You do not know how to take it. As Nagaraj said, you know, you are doing wet arthroscopy cultures, and I'll do it in my clinic. I said, okay. And he asked me to remove everything. And again, he was, you know, friend of Nagaraj. He said, you need to be aggressive, remove everything. Do open arthrotomy, remove all the implants, all the screws, and that is the only solution. It was methicillin-resistant staph epidermidis. Antibiotic change as per culture report, he was put on teicoplanin. I was reasoning myself about sudden swelling after physio. What kind of bacteria is this? Overnight it produces so much fluid that it becomes edematous and tense effusion. And then it subsides, and then after 15 days, again overnight it produces lots of fluid and knee becomes tense. That was not getting into my head. How can a bacteria do like that? It can work only 15 days once and produces lot of fluid, and then it goes for sleep. So I was not happy with the decision of infectious thing, and I also thought of bleeding, as Sujit said, that there could be some bleeding over there, or reactive synovitis, or abuse. I was happy, and ID specialist was very, very happy. See, I could culture the bacteria, and you surgeons are of no use. I called radiologist, and I was not convinced to do open arthrotomy. It is staph epidermidis. I was not sure how the bacteria is producing so much fluid once in 15 days. And my radiologist said, sir, it is hemophilia. I said, come on, how can it be hemophilia? I operated this patient twice in last 2 months. There was no bleeding, nothing happened to him. And how can you say it is hemophilia? And then reluctantly, I asked hospital to do PT and APTT. And there it was. PT was 42.5, INR 4.06. Total count is still normal, CRP is still normal. So now I have 2 pathologies, MRSC cultured, raised prothrombin time, and I was like, I called hematologist and said, see what's happening, look inside it. He said, come on, it's a bleeding disorder. And you have to get factor 5 and factor 7, which causes increased prothrombin time, but they turned out normal. Said, oh, it's normal. Said, okay, don't worry. It is antibiotic-induced liver malfunction, and that is why everything is happening, because you have given 6 weeks of empirical antibiotics without knowing the name of bacteria. The liver is affected, and that's why it is not producing prothrombin in all the enzymes. And he asked for LFT and USG abdomen, and he started vitamin K injections. I said, okay, let's do that. Patient is unhappy, ID specialist still smiling, and I became a bystander, because now it is talk between all other doctors. I was just watching my case being screwed by all of them, and by me at cell. So, I don't know what to do at this stage, and as there are no hands raised, I'll go further. 11 weeks post-op, APTT is 47. SGBT is still rising, LDH also started rising. So liver function is definitely now getting altered, and liver is getting damaged. Total count came to 2,600. I asked for gastro reference, and I asked for repeat hematologist reference. And see over here, his hemoglobin is constantly, this is medical officer chart. His hemoglobin came from 14.9 to 11.7, total count 2,400. Platelets are normal, CRP is normal, enzymes are increasing, and relatives started piling up at hospital. You know, in India, every known and unknown relative will come to hospital, and there were multiple calls and questions bombarded on me, and patient's knee is getting more and more stiff. So patient was unhappy, surgeon was not able to see a way forward. I was dead confused what to do, because I was not sure of any path. And at that moment, gastrophysician and hematologist put him on FFP, vitamin K injections. They asked for more investigations, and I started reading medicine books. Next, all the reports getting normal. I'll take 2 to 3 more minutes more. CRP is still normal. Total count got worsened from 2,600 to 2,200. And team physician called me and said, you need to open the joint now. Why you are worried? What kind of a great surgeon you are? All those physicians were my classmates. They have grown along with me, and they were like friends. What kind of surgeon you are? You are worried of operating a patient. Open it and remove everything. And I was worried with total count 2,200. Affected APT, affected liver function test, bone marrow depression, and you want me to operate? First correct that, then I will operate. And they say, no, you have to operate it now. So second ARS, shall I go in now or not? Okay, so I think I should have called all of you guys because to support me at that time. Because I was too much under pressure to operate. I called another arthroscopist, so that he can support me and say, no, I should not operate. And he said, yes, you have to operate. And you have to remove everything. So I said, oh my God, my colleague is also not helping me. Only anesthetist was supporting me, because he said, I won't give spinal because there will be a spinal bleed and it will lead to paraplegia. And if I give general anesthesia, if the blood pressure shoots up, there will be intracranial hemorrhage. So not fit for anesthesia. 12-week luck strikes. Out of 20 odd relatives, Dur ke Mamaji came, and he said that this guy always gets ill and never gets cured early since his childhood. And hematologist was taking round at that time, and she said, what you are trying to say? And he said, at birth he had umbilical bleeding that lasted for 3 weeks. Anytime he fell down during his childhood, he will develop a big hematoma, and he gets persistent bleeding after tooth extraction. And hematologist was very angry, because she definitely asked this question multiple times to the patient, but patient never knew that because it was all childhood history. So patient was not aware of that these things has happened to him. And then patient was indifferent, doctors were relieved, and we asked for a complete profile, and it turned out to be factor 10 deficiency. Level was 15%, normal is 50 to 200. Just to complete the story, factor 10 deficiency is bleeding umbilical stump is one of the earliest symptoms in factor 10 deficiency. Patient can bleed occasionally or any time. It can be minor trauma, bruising, gastric bleeding, hematoma formations, or hematuria. Severity depends on protein activity. 40% above, they may be asymptomatic, 10 to 40% moderate, and less than 10% severe disease. It is mutate F10 gene, which leads to faulty or deficient factor 10. It is autosomal recessive disorder, and both parents must pass the defective gene to the patient. It is very rare. One case out of half to 1 million. So it's a very, very rare condition. And different diagnosis is all other deficiencies. So male 20 year, 1 year follow-up. I called him yesterday and he took pictures. He has good movement. The bleb which developed, the scar is still there. He is healing well. I am happy. And I called hematologist yesterday and I told her that a good and brave surgeon is not one who operates all the cases, but one who knows when not to touch, as my audience is intelligent. Thank you very much.